Hi, Sarah. Hi, Christian.
I
can't
trying
hear
to...
you. Oh, that's
oh,
okay.
can you hear me now?
Yeah.
Yeah, I was just trying to work out, because I don't remember from last time, how to share the screen for the PowerPoint.
So on mine, you've got your big red one on the right hand side saying leave. Next to that is share. You got that?
Can I have a
and
practice?
Then you want to, yeah, and then you want to share it as slideshow, because otherwise everyone gets your whole screen with the slides in it, and that way it just shares the slides in turn. Does that make sense?
Oh no, hold on, that's not doing it right. Right, so if I go to slideshow and from the beginning. Oh. What can you see anything?
No, still got normal screen.
Okay.
I have also emailed Bav, because I'm having trouble. Bav could only get me on my phone as well. I've been able to join this coming through the Teams calendar. Hello, good afternoon.
Okay, I don't know why it won't. I haven't got my normal buttons up at the side. Shall we see if Bav can share it?
Yeah, he's not on the call yet. Let me give him a shout.
Because I've got the share button. Sorry, guys, don't mean to talk in a technical over the top.
We're nurses, not IT people.
I've only got the option to share it by email. I don't have the share screen option on it for some reason.
Strange. Have you got a black rectangle with a white arrow?
No. Let me just go to my... Share. Oh, hold on.
Let me see if I can, having come in this way.
I think I might have got it. Hold on.
Yeah, that's it.
Am I sharing now?
Yeah, you are, but then you want to do slideshow. So down the bottom, you've got next, well, it's showing as next to your size increase and decrease, there's a little rectangle with a stand under it. Can you see it? Right. Yeah, there you go. Custom. Yeah, that one. If you click that.
What can you see?
No, we can still see it. Go right down to the bottom, Sarah.
Yeah.
You know where you've got the black line along the bottom with all your icons?
Yeah.
And you've got your increase and decrease on size.
Yeah.
Next to that, there's another of those little buttons. Try that. Yeah, try that one.
Anything happening?
No, I mean, what you've got will work, but usually that should send it as a slideshow.
I can't see what you guys are seeing, all right? Just so...
Yeah, I mean, it's fine. It's great. It's just we're seeing all the slides on the left plus the big one in the middle.
If I go from the beginning, see if that does. I can see Babs in it.
Oh, he's Bav in now.
Is it? Oh, which... I've got it as full screen on one screen and not on the other. Oh, you should teach this in nursing degree.
All the stuff we have to know, and all the drugs and calculations and processes, and then suddenly they give us a computer. It's like, where's Bav? Let's see. I'll message him. I wonder if it's because he's in it. I'll just say, can you join and help?
So you can still see the slideshow because I'm fiddling around with it.
Yeah. So it will work. It's just not as good as when you just have the whole screen. So
from the beginning.
Bav's not got my message yet.
Okay. Well, hopefully we'll sort it out.
We
Oh, it's
will.
I've come back on 2 screens again now. What's happening here?
You can see yourself in double. It's great.
I know. It's not, well, no, not really.
Thanks for joining us, everyone. We'll give it till 2 to start and then do some quick introductions, if that's okay with everyone. Oh, here's Bav. Hi, Bav. I'll turn my microphone off and let Sarah explain.
Hi, Bav.
Hi.
I'm not quite sure what I've done wrong. I'm sharing the screen and I'm trying to do the slideshow. But I've still got the slides at the side. And it's coming up on two of my screens here.
Okay, if you just stop sharing.
Got up. Lost my mouse on these 3 screens. Yeah.
And then,
Has it
so
gone?
you've got your slides open. Yeah. Just click on screen. So when you go to share, not window, but screen, you have
In
that
the
option.
corner.
Yeah, so go to share.
Yeah.
And can you see what it says screen or window? Can you see that option?
I've got choice of my 3 screens.
Yeah. Okay, just pick the one
Content
where.
only.
Yeah, content only. Yeah.
You're saying here today.
Oh, yes.
Can you see anything?
No, we can't.
Oh, hang on. Hello, can you hear me?
We can hear you. Yes.
Yeah, we can.
Hi, it's Francine and Chris from the. What have I done now, Chris?
No, that's meant to happen.
Oh, okay, from
Sarah,
the
we
Warren.
can see it.
Okay, perfect.
Is it right?
Yeah, we can
Yeah.
see it.
That's good.
Amazing.
If you can log into
Sarah,
it.
will it throw things if you stop sharing again when we do introductions in just a minute and then you share it? If it's going to mess things up, just leave it. It just means we can see everybody's faces while we do introductions.
If everybody doesn't mind that I've got to try and do that again afterwards, then that's absolutely fine. I'll stop sharing it. Is it gone?
It has,
Stop.
thank you. Well, hi, should we make a start, do some introductions if that's okay, because it is bang on 2. Hopefully some other people may still be able to join us. But as everyone's time is so precious, we'll get started. We weren't sure how many people join us today because we appreciate it's summer holidays and we've had a bank holiday, so we know staffing levels are really short. But because the agreement with Devon Care Home Collaborative was we'd do one of these forums the last Wednesday of every month, we've tried to keep to that, unless it's fallen on a week of half term or something. So anyway, welcome and thank you so much for making the time to join us. Say no, everyone's time is really, really busy. Thought maybe we could just, because there aren't as many people here at this forum as the last one, maybe we could just do a quick round of introductions, because part of what we're wanting to do with these forums is not only look at specific clinical areas and topics and sort of discuss guidances and how we, apply the principles, but also to do some sharing of challenges, enablers, best practice, and just sort of a forum to be able to get to know each other. I appreciate some people do, some people don't, and for some care home managers or nurses working in care homes, it can be hard to actually link in with other professionals at times. So I'll just start and then we'll go around the screen if that's okay. So I'm Anne Butts and I've been a nurse for 39 years. Most of my professional life has actually been in the NHS, but I've had the real privilege the last few years of also working with care homes, which has just been absolutely amazing. And have been asked to facilitate these forums once a month. But pulling in subject matter experts such as yourselves. So really hoping some of you may volunteer to share practice around some topics for further forums. And so saying, I'll go to Sarah, who's an extremely experienced nurse, both in the NHS and care homes and 111 and abroad and in everything really, and has kindly agreed to talk to us today about SBARs. Sarah, over to you.
Hi everyone, lovely to see you here today. As Anne said, I've been a nurse for 40 years, worked across many disciplines, and it was lovely to be invited to speak today about SBARD, and it's very hard to pitch this because at each of the forums that we've had so far, we've had a very mixed audience, some clinical, some non-clinical. So obviously trying to keep the language very broad, but also, you know, trying to make it informative and also be able to meet CPD learning for those of you that are registrants and would like to use evidence of today's session towards your revalidation. So lovely to have you all here today.
Thanks, Sarah. And can I just also add, sorry, if everyone's happy at the end of the forum, those who've been before, we will send a certificate of attendance and also a copy of the slides if you'd like them, and also a template that we've pre-populated in part around NMC revalidation. So whether it's that you're a nurse wanting it for revalidation or just for your own personal development, just one, absolutely no obligation to use, but if you want to use and put in your portfolio, we've kind of aligned where today's session meets those NMC requirements. But what we do need is your email addresses. And what we also were wanting to ask, we've not found a way, we're trying hard to find a way to share these invites as a calendar invite, but we can't do so whilst keeping all of your emails anonymous. We can't BCC it, we can only CC it. So if people are happy to put their emails in the chat, we can send all those resources, and please indicate if you're doing so, if you're happy that we send you invites for further forums in that way. And so also, if you could, I'm saying that, I'm just coming to screen next, which is Simon's screen, and just wondering if there's two of you or more sharing a screen, if you could both introduce yourselves and put your emails in the link so we can send each of you the certificates and things. So Simon.
Right, hi, I'm Francine. I'm the clinical lead at the Warren with the care home in Northam in Bideford. I came out of the NHS 5 years ago after working in many acute. So this is a really good opportunity for me to be able to keep my validation up and just keep updated. But yeah, I'm enjoying it. And this is?
Hi, I'm Christian, one of the nurses at the Warren. Yeah, just looking forward to hearing all about the presentation, really.
You've got a strong mental health background.
Yeah, I've worked in mental health really for most of my career, and then start working in this care home about 4 or 5 months ago. So, yeah. Brilliant.
Thank you so much. And as I say, just keeping in mind, if anybody would like to do a future presentation, we'd love that. Just hearing all this experience we've got here. So next on my screen is Abiola. Have I pronounced that correctly?
Yeah, correct. My name is Abiola Akigbongbe. I work with a Valorum Care group, precisely Douglas House. I'm a mental health nurse, and I've been qualified for just a year plus now. So I just want to use it for my revalidation and update myself. Thank you.
Thank you. Thanks for joining us, Aviola.
Thank you.
Great. Joe, you're next on my screen.
Hi, I'm not Joe Broderick. I'm Joe Emery. I'm clinical lead at Brambledown Nursing Home. Worked for the NHS for many years and came to the private sector about 3 years ago. I've been here in post for about 7-8 weeks.
Wow. still very new then. Loads going on. Brilliant. Oh, thanks for joining us. Really appreciate it. Meg, you're next on my screen. Your camera's not on. I don't know if you have a camera you're able to put on or not. If you are, it'd be great to see you.
Hi, no, I'm sorry. I don't think you're going to have much joy with the camera, or I'm going to have much joy with the camera. I'm Meg Hill, and I'm an occupational therapy educator with the Community Education Assessment Team, which is mainly at the moment with care homes, training in care homes, but we're sort of expanding a bit, and we are about to merge with the UCR trainers, which is the urgent care response.
Yeah, that's great. Thanks, Meg. Really welcome
Sorry
today.
about the camera.
No, appreciate. It's just nice to see faces when we can, so we recognise each other. And particularly when Sarah starts a presentation, it can be very off-putting when you've just got a blank screen. But we don't all have cameras we can use all the time. We can only use what we've got. But thank you. Bav, you're next on my screen.
Hi all, I'm Bav Taylor. I'm the Director of Education for Indigo Development. I'm probably unique in this platform that I don't come from a medical background. I come from an education background, but I do lots of things with lots of great people like Sarah and yourselves, do training, learning and development in lots of spaces. So I'm just here in the background. Great to see you all.
Brilliant, thanks Bav. And Clarissa. Again, we can't see you, Clarissa, but I don't know if you're not able to use a camera.
Hi, I'm Clarissa, the manager in Premier Nursing Home, looking after dementia, complex dementia residents, 80 beds. Been here for 10 years.
Brilliant, thanks Clarissa, it's nice to see you again. And Anne B and Liji. No, maybe they've had to, we'll come back to them. They might have had to nip off. Christian Sandalescu, is that, sorry if I pronounced that properly? No, that camera's off as well. Let's come to Sam and Sasha, because I can see you're both there.
Hello, I'm Sam, I'm the Deputy Manager at Douglas House. I assist the nurses in their clinical needs and things, so it'd be nice to gain a little bit more knowledge. Yeah. I'm Sasha, I'm one of the care home assistant practitioners, and I'm about to start my nurse associate training next month. So
Congratulations, lovely to have you both here, thank you. Karen, are you able to use the camera? No? I know what Karen looks like, so I'll grab her as soon as she does return on screen. Oh, are you there? No. Emma.
Hi, yeah, I'm Emma. I work in the same team as Meg. I am a nurse educator in the Community Education Assurance team. I've been qualified for about 150 years as a registered nurse. My background's in district nursing and tissue viability, and our team writes and delivers education to care providers across Devon, face-to-face and online. And this is a great session for us because we teach about SBARs in our Restore 2 training, and it pretty much runs through all of our education sessions. So this is absolutely fabulous. Love to be here. Thank you.
Thanks. Brilliant, and thank you for coming, Emma. And that's why it's great to have different people, because being as the SBARs all about communication, it's great to make sure that we've all got the same understanding across the board about, you know, how we're using it to make sure we maximise on the opportunities there for our residents and colleagues. That's brilliant. Thank you, Emma. Carla, you're next on my screen.
Hello, I'm Carla. I'm no medical background, just here for Devon Care Homes Collaborative as admin support.
Brilliant, thanks Carla. Roxanne?
Hi there, my name is Roxy. I'm the registered manager of Douglas House. I'm a community nurse by background, and I left the NHS in January.
Lovely to have you. Thank you, Roxy. Kerry?
Hi, I'm Kerry Galletley, and I am the Quake nurse for the Torby Quake team. So I've just come in to support Anne and see how the sessions go, and obviously part for the revalidation as well.
Great, thank you, Kerry. Sharon.
I'm Sharon Ahmed and I'm a care home manager with Evolve Care Group.
Thanks, Sharon. Catherine?
I'm Catherine Hughes. I work for Rowcroft Hospice in the education department. Thank you, Anne.
Fantastic. Thanks, Catherine. And Kerry?
I'm the same, except I'm not Catherine, I'm Kerry. I work for Rowcroft's education team and we're RNs by background.
Brilliant, thank you. So is there anybody who's not introduced themselves, who's reappeared, who wasn't available? Oh, Paula, sorry.
That's okay. Sorry, I'm Paula Gew. I'm operations manager with Peninsula Care Homes. I've been in post 6 weeks. I qualified back in '87, so a long time ago. So I was recently made redundant, so from a head of nursing role, and now I'm an operations manager. So thoroughly enjoying it. And I've been in social care for about the last 20 years. So
brilliant, thank you. Is there anybody else who hasn't been able to introduce themselves? No? Please jump on if you can. It's great to have such a wealth of you all here today. That's really what it's all about, being a peer forum, is to be able to share experiences, understandings, as I say, sort of challenges, blockers, enablers, best practice, and just a bit of sort of support as well around an hour of education out of our busy days. So Sarah, if you're happy, I'll hand over to you. As you know, because we've all done introductions, Sarah's got a wealth of experience. She's co-organising all these forums with me, and she's very kindly delivering on a couple of them, including today. She has huge experience in this area. So Sarah, over to you.
Okay, thank you. Just checking, I've started sharing. Can everybody see the screen?
Yeah, we can, Sarah. Sorry, getting you to take it off after you got it on.
Okay, so
Sarah, sorry to interrupt you. Do you want to present your slides?
Are they not presented?
They're not yet.
Oh, okay.
We can see them, but only as we could before, Bav, whereby it's not showing as a slideshow. No. We're seeing all the slides down one side and the main slide. So it'll work like that, but obviously it's not the ideal.
Okay, let's continue.
Okay. Right, so I'll leave Bav and Anne to monitor the chat bar. With these sessions, it's quite difficult, as I said, to pitch because we have people from clinical, non-clinical, and from an admin perspective. So everybody's coming for a slightly different reason. No intention to patronize people who have got, years and years of experience, but also don't want to make things too deep for people that they can't make use of the session and actually feel that they could make a contribution. So I'm quite happy as we go through, if there's any points that we want to develop into a discussion point, or whether we want to go through the slideshow and then have a discussion afterwards. So, I don't mind. We're all peers together here, so I'm happy to go with the flow on how the presentation adapts to us. So as Anne said during my introduction, I've been a nurse for 40 years, and for a couple of years during COVID, I worked for NHS 111 as a clinical advisor, and SBAR or SBAR, depending on where you've learnt it or where you use it, was a part of every single call that you deal with incoming into NHS 111. And if any of you have made calls to NHS 111, you're probably familiar with the questions that are asked and the information you're expected to have at hand when you make that call. So what we're going to look at today, I'll make sure it's changed, is we're going to look at to know what SBARs is, why and when we might use it, and how that would link to being able to recognise the signs of deterioration in a person in your care. We're also going to have a look at some clinical tools that can help you with that. And in line with our revalidation, we're going to see how this links to the NMC code. Okay, so as an introduction, for anyone who's not familiar with it, SBARD is a communication tool. Now, it isn't used in isolation within healthcare. It is also used within the military and in some education areas as well. But if we keep within the healthcare arena, we are looking at situation, which is the S, background, assessment, the recommendation, and then the decision on onward care. And the why? Well, the use of a specific communication tool helps to underpin the use of the clinical pathways, informal and formal, that we all use every single day. We are always triaging when we are looking at the people in front of us, whether we're doing it formally to be able to communicate to another professional outside of the care home, or whether we are looking to do that, you know, to a professional, either written or verbal. It also helps to support effectively the escalation for onward medical care. So as we all know, communication is key, and factual, accurate communication makes sure that we get the best outcomes, and it improves the outcomes by making sure that that clinical information is shared well. Can I have a quick show of hands in the chat, or just some indication of people that have used SBAR before? I can see lots of hands going up there. That's excellent. Okay, that's awesome. So
in the NHS, sorry, I was just going to say, Sarah, in the NHS, you get no choice these days. Everybody uses SBARs, I think.
I think what's really been noticeable to me, so obviously used it every single call within my daily life within NHS 111. Within the care home setting, which I've worked in health and social care on and off throughout my 40 years of nursing, but over the last, I would say, 10 years, the way that we use it has changed, and the way that we use it at handovers, for example, and not just with our external professionals, has also become a really valuable way forward. And it's been one of the ways that we've helped to enhance education within health and social care as well, because it gives you a chance to explore scenarios and conditions that help to identify learning needs for your staff and team members within the home. So as we said, it is a building block to good communication. It enables you to gather the essential information that you need to communicate with clinicians and departments that can help support you and the resident in your care. And as I said, it can be used in handovers, and it can help make very effective decision making. It helps to escalate, and it can be written, it can be verbal, and it can be urgent or non-urgent. So we've got a multitude of opportunities when we can utilize this tool.
Sarah, sorry, Karen's got her hand up. Are you happy to take questions as we go?
Yes, absolutely.
Thanks, Karen. Karen, did you mean to have you? We can't see or hear you, Karen. I'll try emailing you. I'm not sure if you're having trouble communicating. Sorry, Sarah, carry on.
That's absolutely fine. So this snapshot of what SBARD could look like, and I'm not going to talk you through the whole slide, but it gives you an indication. So your situation, who are you, where are you, and importantly, your contact details. Okay, so if you've ever dealt with 111, you know that they need that detail, because if the line gets dropped, they need to be able to get back to you and to know what they might need to do for you, who you are and what your qualification is, because that facilitates the level of the conversation that you're going to have, the details of your resident, and if you've got any background information on what you've done so far, so a news score, and what your initial thoughts are, what your initial concerns are, so we all know what the situation is that we're starting with. Secondary to that is really, really important that you've got the background. So we might be looking at underlying comorbidities, past medical history. There could be medications that have a high impact on risk. For example, in a fall situation, we really need to know about anticoagulants. We might need to know about antiplatelets and other medications. Really importantly, in the care home situation, you know, is there a DNA CPR in place? Is there an advanced care plan? Are there directives as to, you know, resident and relatives' wishes? And, you know, what are we looking for, or what are we allowed to do to look for in the way of outcomes? You know, is it someone who wants to be hospitalized? Is it someone who wants to have active treatment? Or are we looking for some sort of palliative support for somebody in this situation? We're going to look at assessing the information, the facts that we have in front of us to hand. And there's no right or wrong amount of information in this assessment, because it is what you as a healthcare professional have got access to at the time that you're making the call, or that you're handing over information to another professional or to one of your colleagues so that they can support you. So there's no right or wrong or good amount of information in here. It's literally everything you've managed to collect. And if any of you were on the session we did last month when we talked about APIE, assessment is key in gathering that information. So it's a summary. What you've done so far, have you had to move somebody to make them safe and comfortable? Have you given analgesia? You know, is there any bleeding? Have you stemmed that bleeding? So you're just really, you know, you've set the scene with the situation and the background, and you are collating that assessment as to where you are now that you've got those three components in place. Then you're going to come up with recommendations. So depending on who you are speaking to, it's really important for you to know as a professional, what do you actually want to get out of this call? You know, are you just looking for advice? You know, is it something that you actually think you can manage, but you just want that professional backup and support to qualify and quantify your decision making? Do you actually feel that you need someone to come and, you know, visually examine your resident? Do you know already that they need escalation to hospital? You know, if you are 99% sure that you've got a fractured neck or femur in front of you, you don't need advice, you need an ambulance. You know, so you can make your recommendation. You are a professional, you've gathered all this information, you're going to make your professional recommendation. Whether that's what happens, that's decided in the decision section, but you have the autonomy to give your professional opinion based on the information that you have in front of you. It may well be that you have to discuss with whoever you're on the phone to. So let's say it is 111. They will give you guidance on what to do if there are signs and symptoms of worsening of the condition. So if we were talking about altered levels of consciousness, if we were talking about possible sepsis, so you with your professional at the end of the phone can discuss what are going to be your trigger points to identify if that person starts to deteriorate in front of you, and also what you could do if you feel that their condition starts to improve. You know, we all know the strains that are put on the paramedic services. So if you do have someone who is in front of you and you were initially concerned, but you're following through with advice and guidance that you've had from an out of hours clinician or GP, and you feel that, you know, things are stabilizing, then you can, you know, communicate that to alter the timeframes of the call out that you're going to get. So ultimately, the decision is going to be one where you've communicated all of this information and you come up with a decision that you and the professional is happy with. And it may well be that by this time you may have had a colleague that has been in touch with relatives, so you may have additional information about, you know, would they like escalation to hospital? Do they want to go with them if they are going in? Would they prefer, you know, if we are talking about someone who's entering an end of life phase, but, you know, is showing signs that their symptoms are not controlled, are they going to come into the home? So all the time that you're gathering this information and having this communication, things can be changing and more information can be available, but ultimately you will be making a decision on what's going to happen next. Now, really importantly, how those of us that are nurses and who have done this before will have our own way of how we would, verbalise and transfer this information. But if you are supporting teams and you've got to give them guidance on how you would want them to communicate, you have to provide them with some tools. Now, I don't know what everybody uses, but in the home where I am the registered manager, we use the Restore chart, and there is the SBARs escalation tool as one of the pages in there. And, we use this as a training resource for our staff to make sure that they are familiar with the process, what information to gather, and it also gives them the prompts. Okay, so there may be localized variations on this, and I know that some health boards have their own variations of escalation tools, they're sometimes called, but they are all pretty similar in that you are going to gather the same categories of information before you ultimately come to a decision on next steps. And as we mentioned before, the gathering of a new score to support your decision making as to why you've escalated a call. So if you've got a new score 5, you've already got the factors that have given you that score, so you can discuss that in detail with the clinician that you're communicating with to come up with the most appropriate decision for onward care. So if we keep that in mind and we think about how we would use these tools and SBARs if we were potentially presented with someone with signs of deterioration. So recognizing deterioration can sound quite simple. You are familiar with the people who live within your care or nursing home. You come up with what is their normal, their normal presentation. Are they normally mobile? Can they normally communicate? Do they have a level of confusion that is normal for them? Do they have a level of disorientation that's normal for them? So you would know if something is different because you know them. But if you had an agency nurse on who'd never been to your home before, and they've had an introduction to the home and fire safety, and they've been given all the pictures of, all of your residents, they don't know these individualities. So they need guidance and they need to have some tools at their disposal. Obviously, they've got Restore Chart, News 2 or SBARs, but they need to also be able to use their own clinical judgment. So as we would in any potential emergency situation, we would look at airway, breathing, circulation, any sign of disability or exposure to an environment that could be life-threatening. Okay, so we could have electrocution, we could have flooding, we could have had, a fall from a height, fall from window, whatever. We're going to use that with our Restore data that we collect. And if there is evidence of a possible, so if we've had an unwitnessed fall, we're going to look at Glasgow Coma Scale to assess for neurological impairment. Okay, so that's anything that is not their normal. So their score may not be 15 out of 15 if they already have a certain level of confusion that is normal for them. Okay, and if you are caring for people who are on a dementia journey, then you may not be able to use, traditional methods of recognizing pain. So you may be using something like pain ads, where you're going to watch for facial grimacing, whether they can be consoled, can you distract them, those kind of things. So you're going to have some tools in your kit that are multi-purpose depending on the person that you are caring for. But there are some very easy, recognizable signs of deterioration. So the most obvious ones would be someone who is in respiratory distress, someone who is experiencing pain, whether that's a new or a worsening pain, and someone who is feeling unwell. And often the phrase that I've heard quite a few times as a call handler was, I feel like I'm going to die, especially from someone who's living alone. They haven't got any chest pain or anything like that, but they can feel there's something wrong in their body, and they will make the call and they say, I think I'm going to die. And that, you know, is a huge trigger to get them assessed. And we will back that up with all of the information we've gathered as before. So our News 2, our GCS, will be looking at skin presentation. So we may be looking at, you know, new rashes, the colour, you know, are they clammy, sweaty? You know, what's different there in the presentation of this skin? Their oral intake, you know, are there signs of dehydration? If you know that you have a resident who has been over the last couple of days consuming 500 mils or less of oral fluid, they're potentially severely dehydrated, which is going to impact them. Have they got any urine output? You know, all of this information is going to help you to build your picture of what you may or may not be dealing with. Is someone needing more care and support than is normal for them? Whether they're asking for it or whether you're having to recognize to give it. And has their psychological and mental presentation changed? So we're looking at confusion, expressive behaviors, people becoming deliberately socially isolated without any obvious cause, increased anxiety. So you can see that there are many, many reasons that can be used collectively or individually that might indicate that there is something going on for the person that you're caring for. And as clinicians, it is our role to be able to take them either in isolation or as a group, be able to discuss and communicate them with healthcare professionals to help come up with the best possible onward care option and treatment that may be required. You know, we're not asking for people to make a diagnosis. If you think you know what's wrong, then you should say, I think they have a chest infection. I think they have fractured their femur. You know, I think they may be septic. You know, you've got the clinical knowledge, those of you that are nurses and have been exposed to certain situations, and you should feel confident with the tools that you have to be able to use that clinical knowledge and be able to rationalize what you think is happening. It doesn't matter if you're wrong, but the more information you can give, especially to someone at the end of the phone who can't see what you're dealing with, the more information you can give them, the better outcome you can help to provide for the resident that you are supporting. Now, those of us on the call that are qualified nurses, obviously everything that we do, everything that we learn, and everything that we share, either as educators, whether that's formally or informally, we have to be able to understand how that links to the nursing and midwifery code. And in relation to SBARs and the recognition of deterioration, we need, and we always do demonstrate that we prioritize people. You know, we care for people every single day. They are the center and driving force of everything that we do. And we, as healthcare professionals, make sure that on their physical, social and psychological needs are addressed and cared for. And that's also important during an emergency situation. We also have to be able to be clear that we practice effectively and we use the most relevant, up-to-date research and best practice when we are implementing clinical practice. We need to make sure that we preserve safety, not only for the residents we care for, but also for our team members and staff within our environments who could be put at risk in emergency situations. And at all times, we have to show that we promote professionalism and trust. And that is how we demonstrate our knowledge and our skills. And we ensure, like today, that we try to share knowledge amongst our peers and that we can evidence that we work continuously on maintaining our levels of competence, and which in turn improves our performance within the workplace. I'm not going to show it now, but we will post a link to, and it is in the resources that you will receive. There is a very good video that's on YouTube. Some of you may have seen it before. It's only 9 minutes long, but it is actually a demonstration of an emergency situation and how it's dealt with no SBARs in place, and then how that same call is dealt with when they have an SBARD in place. And it is very significant, the time frame and the use of the information that's gathered during the process. So I would highly recommend that if possible you have it a look, and also if you want to share that with your teams, then I think they would find that useful as well.
Thank you, Sarah. A huge amount of information there, which is really helpful and great, as we've got such a breadth of people with experience on the call today. Are there any questions for Sarah, or just observations people would like to make about challenges they've had using SBARs, or where they have used SBARs or similar, and how that's been? Emma.
Yeah, firstly, thank you very much for that. It was really, really helpful. And as you say, loads of really good information there. One of the things that I found in feedback that I've had around the SBARD tool when I've been using it in education in care homes is when we are kind of talking to care staff, how comfortable they feel with the recommendation part of the tool. Excuse me. And when we talk through about coming to a decision that is, kind of mutually agreed. I've had quite a lot of feedback. The care staff don't feel confident, obviously, to say, I think it's this, I think it's that, if they're not a registrant. And that's, I find that a little bit difficult to guide them through. I don't know what other people's thoughts are around that.
I think that's a really valid point, and I've experienced that myself with supporting, care staff, house leads, and care practitioners within, the social care setting. I think what's really, really important is to break down that fear and make the use of the tools something that they do, not just when an emergency or a deteriorating situation happens, but something that they get used to doing, routinely, and even practicing, like on a GP round. If you're going to put someone on a GP round list because you think they might have a chest infection, use it as a training opportunity to go through, I think as a registrant, as a nurse, that this person has the symptoms of a chest infection. Can you have a look and see what you think you would say if you thought that that might be the case? And, you can then take them through, the situation, the background, the assessment, the use of the data that they can help you to collate if you were actually completing the SBARD for yourself. But also when it comes to recommendations, as I said, it's not all about saying, I need a 999 ambulance. I need a doctor to come out now. It's about having information to facilitate a conversation. You're actually having a discussion, and it's during those discussion that the recommendations and ultimately the decision will be made. So you can't get it wrong. You might have an opinion. You might say, I think this person has a chest infection. What we may not know at that stage is, because we've had this here with someone who was visiting and we didn't know anything about past medical history or anything like that, but this person had actually got a history of COPD, so they've already got an underlying breathing condition. But the way they presented collapsing in the home was like they got a severe chest infection. We got the bubbly chest, they felt hot, they looked and felt unwell. So there's no right or wrong way, but encouraging people to not be afraid of the process, because any one day something could happen in your care home where your member of staff would have to be the one passing information over the phone, and they need to be able to have access to a tool, even if there's scribbled notes on it that's got there's a news score, they're obviously in pain, they're crying, give the physical presentation of what's in front of them to help build the picture, and that will aid the recommendations. We're not asking for people to diagnose, we're not asking for them to say I 100% need a doctor. We're asking for them to give information to help make that ultimate decision. But I think it's a really great tool that we should all share more information on in the care home, because I think it can help support all of us as nurses if more people within the home have that degree of knowledge.
I think what also has come up when we've been using this in education is that it's a bit of a fine balance as well, because if somebody has made a decision before they get to the escalation process that this person has got X, so I'd use an example of a UTI, and actually, and I kind of use this in my education settings, is that if you give the soft signs of a UTI, they can also be similar to dehydration, as an example.
Yep.
So once somebody's made a decision that you know, somebody they're supporting has got a UTI, then the information potentially they're going to give is going to be channeled towards a UTI diagnosis, as opposed to giving that kind of systemic look and assessment at that person. So that's I think why the SBARD works so well, is that yes, they have got abdominal pain, yes, they are a bit more confused X, Y, and Z, but actually, you know, there are other things happening. So whilst we kind of talk about decision making and having an opinion, make sure we're gathering all the information, not just what we think it is, because we're not diagnosticians ultimately.
Exactly.
But yeah, thank you. That's really useful. Thank you.
Sharon,
Thank
you got a
you.
question?
Sharon.
No, I was just going to say that we use the SBAR for sending GP rounds. You know, when you send for the details for the GP rounds, it can be quite vague. And when they come for the rounds, if it is not the physician who is writing it, the person who's doing the rounds find it quite complicated. So we use the SBAR for the GP round. So that's quite helpful in a care home setup.
Yeah, absolutely. And the more structured you can be, the more efficient the GP round can be, and the better outcomes again that you can get, because there are occasions where symptoms can be very similar. You know, and you know, when they were, you know, having the campaigns on sepsis, you know, some of the soft signs, you know, can be attributed to lots of different conditions. But actually, during that campaign, trying to get people to think sepsis, you know, did on some occasions sideline some other conditions, because you know we were all focused on the one thing. So I think SBARD is one of those tools that helps you to keep an open mind and actually just gather everything, so that you can have, you know, a real good umbrella view of what you may be dealing with.
It's really helping with that collaborative decision, isn't it, Sarah?
Yep.
So everyone's putting in the information they've got, but the responsibility isn't on the person from the care home, as has already been said, to make the diagnosis, but it's all supporting that collaborative decision, because in the care homes, we're the ones who know the residents the best and know what's normal and what's normal for them, hence the use of the sort of News 2 and Restore 2 as well.
It's also a very good debrief tool. So if you've had a situation, especially if it's been an emergency deterioration of someone in your care, and that can be really distressing for care staff if they haven't got an in-depth knowledge, but they're involved either as an observer, a runner, whatever the part they've had to play, to be able to go through afterwards and use the SBARD process to explain to them, thank you for your part in that. You know, it was really valued. So you're giving them the sense of worth and value, whatever their role was within that situation. But to give them then the opportunity to learn, to gain knowledge about what they've just witnessed, so that in a similar situation moving forward, they might have the skills to actually recognize someone who is deteriorating. You know, so use it as a learning tool, and use it as something that helps with their professional development, because you know, many people that are coming in to work in health and social care now are actually looking for a career. They're not just looking for a job. They want to learn, they want to develop. Some people want to go on and be nursing associates, or they want to go on and do their nursing degrees. There's all sorts of, you know, opportunities. But if you have people who are keen to learn, debriefing using SBARD is a huge tool with a wealth of information behind it.
Thanks, Sarah. Are there any other questions or observations, or where people have found it useful? There's Catherine, I'm imagining for hospices as well. It's really helpful when you're looking at that level of deterioration and trying to understand. So whether it's about somebody potentially coming to you or giving some support through hospice at care or however, I would imagine it's a really useful tool for you to have the information presented in that way.
Yeah, absolutely. As you say, then everybody's on the same page, aren't they? And you're receiving it in a nice order that you can understand and ask questions about. I know the community team are using that, and the inpatient unit too.
Yeah, and that again, I guess, would link, Sarah, with what you were saying, is that especially when if someone is end of life, it's very distressing, especially when they're residents that, you know, the staff have all got to know really well. So to be able to go through that format and know that you've used that in communicating with not only the acute, but also people like the hospices, to know that you've used all that information that you had to hand and shared it in the best way possible, must be really reassuring for staff in sort of debriefs and things afterwards.
Yeah, and I think one of the things we haven't really touched on here, but another use I've seen of it is with someone who is in a mental health crisis. So, you know, we're not looking, you know, at a physical injury or anything like that, but something is happening for this person, and we may not know what's triggered it. We may have an idea what's triggered it, but all we've got to go on is what we can see, how they're presenting, what might be going on in the background if we know, you know, and what do we think we need? You know, do we just need someone to be at the end of the phone initially to help with some de-escalation? You know, it doesn't necessarily mean that we need someone to come out. You know, we may be working within an environment where we've got registered mental health nurses, you know, people with experience, you know, in that field. But being able to collate the information helps you to identify, for someone who's going to try and provide you with support, how they might be able to help you, because it can be really frustrating being on the end of the phone. You really want to help somebody, but you don't know if you've got the whole picture. So again, you're trying to pick apart the SBARD over the phone with people. So you might use it as the communication tool and go through it in the order, you know, that we've discussed. But when you're actually having the conversation to come up with a recommendation and a decision, you actually might have to go back and unpick the situation just to see if we can find out something else. Sharon?
I just would like to mention a situation which happened to us recently in relation to multiple teams involving, from ARMS team to the GP to mental health team to everybody in the world, for a resident who was escalated to a level that needs sectioning. To get that services to pull together, SBARs served a vital role in it. So what you communicated to the doctors for the physical, psychological, and the psychophysiological element of it to pull together, I had to sit with my nurses to see how would you get somebody out to do a sectioning on a bank holiday Friday evening. But it helped and it worked. But we got an ambulance within an hour, and we got the ARMS team in by 5:30 in the morning. So I think the SBAR played a vital role in it. You could easily identify the physical ailments which is related to, and maybe alleviate the physical ailments in it, so that you can prove to the next team that the psychological factor is responsible for the escalation of this behavior. But SBAR correlates the whole system together, and when you speak to an MDT, it gives you a good kind of a tool to speak from, an objective tool than a subjective feeling of I think. You can say, as per the SBAR, that's how this tool, I've used it for at least 10 times that evening to different authorities, and it works. It really works.
Yeah, I mean, some of you may have experienced that sometimes when you make a call, maybe to the out of hours service for some advice or guidance, you will be might be referred on to someone else. You've actually got to go through the whole scenario again. You've got to explain that SBARD again. So if you've actually collated this all into a tool, you are going to save a lot of time, and you will save any ambiguity, because you know that you will be giving exactly the same information to the next professional that you want to try to give you some support. And another use that is not as common in the care home setting, but is increasing in use, is with pharmacies, especially out of hours pharmacies, if they're trying to support you about, you know, whether medication that you've got in use is actually being effective. And sometimes they will actually ask you for your SBAR to help them to support you in that. And the reason that that's becoming more useful is because, you know, we don't always have access to a doctor. You know, when there are resources are under strain, you know, people may be referred to a pharmacy. You know, they may be referred to a minor injuries or, you know, whatever. You're not always going to be able to get the professional that you think you need to speak to. So making sure that you have been able to collate effective information for sharing, you know, is really crucial in that.
Thank you. Are there any other sort of observations about SBARD or questions that anybody would like to pose, particularly about SBARDs? What I'll do then, Sarah, if you're in agreement, like you said, we won't share the video now because what we've been trying to do is finish a few minutes early so that we can ask everybody to complete the evaluation form. This is only the third forum. We're really keen to understand what people want from the forum. So is it what you're anticipating? Any suggestions for future topics? Any suggestions about how to improve the forum to meet the needs that people here have got, or even suggestions about how to advertise it more widely to enable more people to come and share. So in a minute, I'm hoping Bav is going to, thank you, Bav, in the chat, Bav's going to share the link to that feedback, to that evaluation. Once we've received that, unless you put in the chat you don't want your email used, I'll use that email to send out the resources to you. And also, if you're happy for me to send out invites for the future forums coming up. So at least they're in your calendar, which a lot of people have said would really help rather than just knowing when they are. Be really keen also if you have suggestions for, hopefully you've all seen the flyers with our proposed future topics, things like pain and management, end of life care, nutrition and hydration. But we'd really like, thanks Matt, we'd really like to know what you would like, and really like to invite people to come and talk about topics which, just as Sarah has done today, topics which you're knowledgeable about. We've also had suggestions. People said they might like to come and do it, a couple of them between them, coming from different angles. Brilliant, perfect. It's all about sharing knowledge and having that opportunity to sort of have that peer forum to discuss, share best practice, share challenges, anything at all like that. So please do anytime email myself, Sarah, Kerry as well. I know from Torplain South Devon's been hugely supportive with care homes attending. So Kerry, I hope it's all right me saying via you as well. Is that okay? Yeah, thank you. So yeah, just please do fill in the evaluation. We won't be able to keep the forums going if we don't have evaluations filled in. So please do fill them in. Please do be brutally honest. We're finding our way as to what's going to work best, and we want to, you know, continue to improve upon the design of the forums, not the content, Sarah, that was fantastic, but the design of the forums and how we approach them. So if there are any further questions, if now, please shout. Sarah and I think will probably stay on until at least 3, although it's only five minutes away. Oh, Sarah's put the video up there as well. Once we receive those evaluations, to say, I'll send the resources, and please do let us know if topics you'd like, and please do volunteer yourself or others to come and actually lead some of the discussions. It can be more of a discussion than it has to do a full-on presentation like Sarah did. It's great when we have that, but just whatever format you'd like. So thank you so much. Oh, Sharon.
I was just wondering, like maybe if it's all nurses who are experienced in SBAR, it's actually quite easy for us to just say automatically from back of our head. But if it is new nurses and if it is new people who are doing this for the first time or second time or until they get used to the system, because sometimes when we use the SBAR, the complexity of the situation can be very subjective. You know, you can decide, it makes you nearly a decision making tool rather than a approach tool for somebody else to make the decision. I don't know whether it makes sense, but maybe if there is a tool when you send the pack to analyze the SBAR in a simpler form, in a more detailed format, that may be helpful for the new nurses. I'm just aware that somebody has qualified recently. And when I used SBAR for the first time, it was overly confusing to me. And I used to refer and re-refer and tell, because as per the SBAR in hospitals, you have to call a registrar or a house officer or whoever. And I used to call wrong people all the time, just because that the complexity and intensity I couldn't understand with that lack of experience in understanding that format. It's not very simplified if you are not experienced for a long time. So it may be an idea that when you send the pack or develop a pack where it is simplified for the new nurses, just considering the experience.
It is actually a topic that Anne and I are working on for OSCE nurses and for care practitioners. So certainly there may be an opportunity for making access to that kind of information from a basic level, moving on to more enhanced, so that it would fit the skill set of people, you know, within the care home environment.
Yeah, I think that's a great idea. We won't have it ready because my aim is to get the resources sent out today, if possible. Apologies if I don't get them out to everybody. I'll be working through it. So we wouldn't be able to do it sort of now with that pack, but definitely a good idea, Sharon, that we can use what we're working on to do that and to share with everybody. Catherine.
Probably about 10 years ago when I was working with the care homes, we did develop a really, unbelievably simple version of the SBAR tool specifically for resi homes. And so maybe I can maybe share that with you, and then you can have a look at it. It is very, very simplified, but it just is very much aimed at skilled non-registered.
Excellent.
That would be amazing, Catherine. Thank you. And that's exactly what we're hoping to develop here with the forum, is that kind of sharing, you know, not sharing of knowledge as well as, you know, examples and experience. So that would be amazing. Thank you. And would you be happy then that we share that out with Devon Care Home Collaborative and the people who've attended here today?
I would, yeah, definitely. I mean, it probably doesn't have the decision aspect on it. It's just the SBAR, but it's not got the D on it. But yeah, no, have a look at it, see what you think.
That's brilliant. Thank you. Yeah, the D's new, isn't it? So that's really helpful. Thank you very much.
Thank you. Thank you to those that are doing the feedback forms. Can see that going through.
Yeah, that's amazing. We really do look at them and pull out from them. Yeah, obviously, we've only had 2 forums so far, but those 2 we used a lot, haven't we, Sarah? We've looked at and Bab.
It's really useful to know, because it's quite a diverse audience, the positive aspects that people find, and also, you know, the ideas for information that we can either include in the future topics that are already set, or that, you know, we might look to include in any future programs.
And also, I suppose, the possibility, I'm just talking as people are filling out, I don't stop anyone filling the forms in because I know we're sort of at the hour now. If there were subjects that people felt it'd be really useful to have certain groups for a sort of 10-minute discussion in, we could do something like that. You know, just whatever suggestions anyone's got about how to run these forums, and it could be different for different topics, obviously.
Anne, can you just, what's your new email?
Yeah, sorry.
Well, it's probably not even new, is it? But yeah.
Well, yeah, it is. Yeah, compared to 28 years, no, gosh, who am I kidding? 39 years of an NHS email. I keep knocking 10 years off. That really shows my age. Yeah, it's just Anne at Indigo. Hang on. I'm to think here. Yeah. Go on, Bav.
I've just added it. I've just added it
Oh,
in the chat box.
thank you. I'll just copy that. That's so
that
much
makes
safer.
more sense, definitely.
Thanks.
File. Okay.
Hey.
Can we stop the recording now? Can't hear you, Bav.
Sorry, I can't. Can you? If you go to top where it says more with 3 dots, record and transcribe, has it got the ability to stop it there?
No.
Right. Okay. Let's all leave it.
I'll leave it and come back. Okay.
Yeah. Abiola's back.
Abiola, are you okay?
I'm okay. I was just removed from the conversation.
Oh no.
So I'm back now.
Fine.
Did you get the link for the evaluation feedback?
Yeah, I've done it.
Oh, fantastic. Thank you.
Yeah.
Any topics that you'd like to suggest for further forums, or anything that you would potentially be interested in talking about yourself?
I won't mind if there's something about a leadership role of a nurse.
Okay. Cool. Brilliant. And is that something you might be interested in leading a talk about, or anybody you would recommend that would be good? Or
Well,
you'd like us to find someone?
You can bring someone.
Okay. All right, that's great. Thank you, Abiola, and thanks for your time today. Really appreciate it.
Yeah, really lovely to have you. You take care.
Thank you so much.
See you next month.
Okay.
All right.
Bye-bye.
Bye-bye.
Bye.
Sarah, it shows that you're one of the organisers. If you go to, you know, where at the top it says chat, people, raise your hand, then it says more, ... Click on more, please. Record and transcribe.
Yeah.
Baisha, can you stop recording there?
Yeah, can I have the transcribe when you finished it?
Yeah.
No, I haven't. That's grayed out for me. So.
Yeah, it's great for all of us. So
it must
I need to
just
check
be Sophia, I think, set it up, didn't she?
So she could change the settings, and what you can do, you can make a few people like organisers and have the rights. Fine. Okay, let's end this now.
Yeah, if we end it, then
jump off.
Come back
Yeah.
in. Oh,